The topic is decidualization. So let's start by, no. Can you hear better?
And the headset maybe?
The headset.
Headset was better.
Okay.
Yeah.
Now? Let me see. Okay, much better. Okay, thank you. So let's start by saying that we know that because women, pregnant women, they undergo scan in almost all cases at the beginning of pregnancy, the prevalence of an ovarian cyst in pregnancy is around 10%, quite high, 1 in 10. But luckily, most of them, they resolved spontaneously. So we have only 6% during the second trimester of pregnancy. I selected 2 prospective studies from the literature, run in London, one at St. George's Hospital and the other one at King's College Hospital, just to check the prevalence and the natural history of these ovarian cysts. So, Condu's experience, 3,000 pregnant women, and we can see that in 86% of cases, there is a spontaneous resolution. 6 cases underwent surgery during pregnancy, and in 4 cases because of a suspicion of torsion. But only in 1 case it was documented a torsion. 17 underwent surgery, and as you can see, the histology was benign in 16 cases and only 1 borderline. The other experience, again, 3,000 patients and 85% spontaneous resolution. Surgery, no cases of torsion, 33 histology, and in all cases, benign results. So we have 6,000 women, pregnant women, only 1 borderline. And we know that the prevalence of carcinoma, the risk of malignancy, is 1 in 25,000 pregnancy, more or less. We had 6,000, 1 borderline. Ovarian cancer, 1 in 25,000. Now, this is the description of histology in Hoover's series. You can see the distribution, dermoids, corpus luteum, and 3% carcinomas, 3% borderline. In all these cases, the mass was removed surgically. So, how can we make a diagnosis in pregnancy? How can we manage? So, in the presence of a cyst like this one, no doubt, similar to outside pregnancy, is the dermoid. The same, unilocular with the ground glass, same rules, endometrioma. In our experience, we had some strange cases, but according to pattern recognition, we could make a diagnosis even in pregnancy. Here we have a bilateral solid ovarian mass, very well vascularized at color Doppler. She was in 16 weeks of gestation, and it turned out to be Krukenberg or metastatic in any case. It was a lymphoma. So, solid, bilateral, same pattern recognition. And in this patient too, very large solid ovarian mass, look at the vascularization, malignancy, and it turned out to be a Krukenberg. But the critical point, and now I arrive to the center of my presentation, is ovarian masses with papillary projections. Because which rules can we follow during pregnancy? If I scan one patient and I find this unilocular solid cyst, but with 1 single papillary projection, hyperechoic shadowing, I have no doubts. It's cystadenophybroma, benign. But what about these cysts? In 2004, I scanned this patient, and I saw during the weeks these papillary projections growing very fast, and they appeared so very well vascularized. So I made the suspicion of malignancy. The patient underwent surgery, and I wasn't aware about this diagnosis. It turned out to be a decidualized endometrioma. Decidualization is the transformation of endometrial stroma fibroblast into decidual cells, and we can find ectopic decidua everywhere. And very often in the ovaries you can find that. And of course, you can find that in the stroma of the endometrioma. So, let's look closely at this ovarian cyst, at this decidualized endometrioma. Look at that. Do you notice something that could help you in differentiating this ovarian cyst from borderline tumor, from invasive tumors? To answer that, we collected 18 cases from different institutions, and we tried to describe the characteristics. This is a panel. All of them are decidualized endometrioma. Again, do you notice something in common? We notice only this one. We notice this feature, some rounded papillary projection with a smooth surface. So we went back to the series and look at the comparison, decidualized and borderline. It's quite impressive. Borderline, usually there are multiple papillary projection with an irregular surface. Not the same here. Swollen, I would say, rounded, smooth surface. So these are the data. Pictorial paper. So 18 decidualized endometrioma, and we can read together the characteristics. So most of them are unilocular solid or multilocular solid. The echogenicity, usually ground glass. We have a papillary projection in almost all cases. Only one case was unilocular. And the surface was irregular in 18% of cases, so smooth in 82% of cases. When we look at the confidence of the ultrasound examiners, you can see that in around 60% of cases, the examiner was uncertain or she made an incorrect diagnosis of suspicion of malignancy. And in some cases we said perhaps can be a borderline, and in one case we said it could be a primary ovarian cancer. The computer? Okay, let's look together at some example. So the pregnancy, and you can see again one unilocular solid with this type of internal wall. One example. The other one with vascularized papillary projection. But when I came in scanning this patient at 24 weeks, I was a little bit impressed because they're very, very, they're a lot, and I was a little bit uncertain. The vascularization was very high, but we decided to wait, not to do nothing, and at 31 weeks gestation, there was spontaneous resolution. And so now, we can only be able not to manage only this patient, but in the presence of this one, we can at least make the suspicion of a decidualized endometrioma. When can be sure 100% that it can be decidualized endometrioma? When we know that the patient had a previous scan just before the pregnancy or at the beginning of pregnancy with the diagnosis of a typical endometrioma. So in this patient, I can say we can be sure. So we can propose a conservative management. But, and we know that in these papers, Guerriero, Barbieri, Sionesh, they described cases when they observed the patient during the pregnancy and they observed the resolution, the shrinkage of the papillary projection. And look at this one, 16 weeks of gestation. I scanned this patient because she was referred to me, the pregnancy and the adnexal region. Are you confident about cancer, borderline, decidualization? Very difficult to say, don't you think so? Lille, very difficult. Would you like to look at the color? Okay. Oh no, I want I want first to show you one thing. I was very uncertain because, okay, the lesion, but look at the peritoneum. This is a clip. Okay, the lesion, and wait a second. No, not here. Perhaps at the beginning. Look at this one. Okay, let's move on to another video. Okay, look at this one. This is the Douglas. And so I saw this echoic tissue, very well vascularized. Is there Luca somewhere? No, Jeroen, are you afraid? Does it look like carcinomatosis or what? I was really uncertain. So the patient underwent a magnetic resonance, and we had a similar uncertainty about that. But looking better in the previous scan, I found one scan with a suspicion of endometrioma at the beginning. So we decided with the patient to wait, and I scanned the patient again 4 weeks later, and the situation was absolutely similar to that. But at the end, I scanned this patient 3 days ago, and she delivered last January, and the left ovary returned to be with the endometrioma. So it was completely filled in with this solid, very well vascularized. But I wanted to show you this case because to me it's the first time that I see decidualization of the peritoneum at ultrasound. Because in this patient, I don't know if I put, okay, this is the peritoneum now with no solid tissue. Are you satisfied? Are you convinced of that? Not really. Do you notice something?
You didn't have the history of the endometrioma. What happened with the patient?
With the patient?
You would not have the scan that showed the endometriosis.
No, that's right. The same. I was really very uncertain about so I wanted to perform laparoscopy just to look at the Douglas. So after magnetic resonance, the colleague was uncertain about the lesion, but at magnetic resonance, she didn't notice any carcinomatosis on the peritoneum. So not because of that result, I was 100% convinced, but we went on, we were lucky, and so just you are right, but because of I found this scan, the first scan, my scan was July, and so I found a previous scan last April with an endometrioma on the left ovary. So that's why it was swollen, very well vascularized. Echoic tissue in the Douglas, but I know how carcinomatosis is. When you push in the Douglas and you have carcinomatosis, it's not so soft. Did you notice? I could push and it was elastic. I don't know the English for that. But it's one single experience. So we decided to went on because the patient was very, very determined not to go on into surgery. So to conclude, now we have the description of a series of decidualized endometrioma. We can apply, we can be sure when we have the previous scan with endometrioma. Now, what we want to know is the result, the distribution of malignancy, and if there are some characteristics we can use to discriminate when collecting unilocular solid cysts with papillary projection. We have not published yet this data. We collected 34 ovarian cysts with the papillary projection, and here you can see the distribution. 56% benign, 35% borderline, 9% invasive ovarian tumors. Don't be afraid about these three, because I'm going to show you the images. Are you ready? Okay. The first one, the only endometrioid adenocarcinoma, happened in my institution. Here is the case. Some years ago, at cesarean section at 31 weeks, and it turned out to be an endometrioma adenocarcinoma, endometrioid adenocarcinoma, sorry, G2. Look at the papillary projection. So quite large portion of solid tissue and a very large ovarian cyst, the only case. But look at the 2 cases of immature teratomas from Luca Savelli. The first one we included in the series because there are papillary projection, but look at the morphology, completely different from decidualized endometrioma and so on. This is one case, this is the second case. So 6 centimeters with this appearance. That's all. If you want just to conclude the event, do you want to try together to guess the diagnosis in front of an ovarian lesion with a papillary projection? 3 minutes. Are you ready, Walter? You have to decide. It's an MCQ test for you. What's this one? Quickly. You have just to guess. Decidualization. Okay, what about this one? Gianfranco. Borderline. No, this one, or this one. It's one single patient. Borderline, invasive, decidualized. Impossible to say, but it was decidualized endometrioma, just to tell you. What about this one? Borderline. How many borderline? Okay, borderline. And you, Dirk? Invasive. You don't know. Very difficult. It turned out to be a decidualized endometrioma. But, so the final results, my message is not that it's easy. Absolutely no. We are studying because we described decidualized endometrioma, but now we want to put together all these unilocular cysts and to be honest, to say it's possible, not possible to say. But let's move on. What about this one? Decidualized? No. Borderline? Borderline? Invasive? Nothing? It's something, because she underwent surgery. Borderline. Okay, irregular, something. Can you see, it's not growing from the lesion, but we could argue about that. What about this one? Correct. Great. What about this one? Difficult. Very difficult one. Decidualized. What about this one? Because you you saw it. What about this one? Why? Grape, irregular. That's fantastic. Okay, we agree on that. What about this one? No, you're right, because it includes a large part, but look at this one. Borderline. What about this one? Borderline, correct. What about this one? My first one. Yeah. And what about this one? Borderline. Serious type. And the last one. Are you ready? 26 weeks gestation. Unilocular solid, around 4 centimeters, with vascularization. Borderline or decidualized? Borderline. You're invasive, not invasive. How many borderline? How many borderline? Most of you. This was my diagnosis at the 26 weeks gestation. So we decided with my director, with the surgeon, to, even if I told the patient probably it's borderline, why do we have to perform surgery right now? Shall we wait? Shall we follow the patient? And perhaps if it will grow, we could anticipate the cesarean section. Otherwise, we will see. So at 33 weeks gestation, what do you expect? No, no, absolutely similar. Do you change your mind? No. How many borderline? Okay, the diameter was absolutely similar, and I scanned this patient the day before coming. So I will tell you the answer. Thank you so much.